Hello and welcome to Ask the Expert series from functiontofitness.co.uk. My name is Benoy Mathew, specialist lower limb physio. In this series we'll be looking at interviewing various experts in various clinical areas. In this episode I'll be discussing about hip dysplasia with Mr. Jonathan Hutt, who is a consultant hip surgeon. Few months ago, I spent a day in Mr. Hutt's clinic. Jonathan Hutt is a consultant hip surgeon who specializes purely in hip surgery. He covers all aspects of hip disorders, including joint preservation and minimally invasive surgery like periacetabular osteotomy for hip dysplasia, and also hip arthroscopy for hip impingement. So it's quite useful from a therapist point of view to understand the surgical indications and also knowing the various imaging options which are used in the diagnosis of these patients. Big thanks to Mr. Hutt for letting me having the opportunity to shadow him in his clinic. What we discussed in the interview was mainly on hip dysplasia. So we're seeing a growing number of hip symptoms in the athletic population, and especially the female population. One of the diagnoses which I see pretty much every week is hip dysplasia. Hip dysplasia is a known risk factor for hip arthritis, and one of the leading causes for early replacement in women, especially below 40s and 50s. So I'll be discussing the typical presentation and also looking into the various management strategy when rehab has failed. So over to the interview.
Hi, my name's Hutt. I'm a consultant hip surgeon. I run the hip preservation unit at St George's University Hospital in South London, and I'm also part of the 40th Clinic.
So thanks, Mr. Hutt, for joining us today. And as you know, hip dysplasia is an extremely common condition for hip pain, especially in active female. There's a lot of awareness on osteoarthritis and hip impingement. Why do you think there's poor awareness on identifying, especially among health professionals?
Well, hip dysplasia is a really interesting topic, and the sort of adult form of hip dysplasia that I tend to see is I think slightly different from what people traditionally think dysplasia that you see and treat in childhood, because I think it's a lot more subtle. So whether it's missed at a young age or whether it's something that develops in adolescence, I don't think it's completely clear. In terms of picking it up, it's a common thing in my practice and obviously a common thing in your practice as well. But actually, I think as a general source of hip problems, it probably isn't that large a proportion of patients. I think awareness of it is very important. And I think that people are becoming much more aware of problems that cause hip pain in the young adult population, both in primary care and amongst orthopedic non-hip specialists. I think that as we move forward, it's really just people having it on their list of possibilities that's going to help us get these patients into clinics and into treatment quicker.
Yeah. And in your day-to-day practice, what's your typical presentation of hip dysplasia you see in your clinics, and what will be your key differential diagnosis as well at the same time?
So I think if we, ignoring the imaging side of things, the typical hip dysplasia patient is usually young, female. They're usually very active. The hip dysplasia, I think, gives you a range of motion that often makes you very good at sports like dancing or gymnastics. They would have had some, or they would not necessarily have had any problems throughout their childhood or their teenage years. And they'll come with a sort of insidious onset of hip pain usually that tends to occur at a low level and then gradually worsen and impacting their function and their day-to-day life in a sort of progressive manner. They often are quite hypermobile. Their range of motion is often still very good. They sort of present very much like an impingement patient, and a lot of their symptoms, the way they describe them in terms of their distribution and what you find in examination, will obviously look very much like an impingement patient as well, safe perhaps for the range of motion, and that's clearly very high on the differential diagnosis.
And what's the natural progression of dysplasia? Do you have much data? Is it a risk factor for osteoarthritis, or some will not get it?
So I think that's quite an interesting question. It's certainly true that if you look at the spectrum of hip dysplasia as a whole, it is a strong risk factor for developing arthritis in the future. However, I don't think it's a guarantee that everyone with hip dysplasia will develop arthritis. I'm certain it varies according to the individual and the severity of the problem. For this reason, when we see hip dysplasia sometimes just radiographically, but in asymptomatic patients, that's clearly not an indication to do anything about it.
Yeah, and what about surgery? Obviously, when people have exhausted all options like medications and physiotherapy, when do you think surgery would be appropriate, or who sort of would be an ideal patient for the types of hip surgery available for hip dysplasia?
So clearly the ideal surgery for hip dysplasia is to correct the anatomy. We're lucky in that we have a very powerful operation in the periacetabular osteotomy to reorientate the acetabulum into a more normal and functional position. In terms of so in terms of the ideal sort of patient for the surgery, I mean, clearly they have to have a symptomatic dysplastic hip. The hip must be congruent, and it must be at a stage before there's been onset of any degenerative changes, as clearly there's little value in reorientating a socket that's already begun to wear out. And clearly the level of symptoms is important. Despite the advances in surgical technique, it's still quite a reasonably big operation to go through. It has a reasonably lengthy rehab, and so clearly the symptoms and the potential expectations of the patient have to justify that sort of input.
Yeah, and what's the long-term outcomes with PIO, and does it prevent osteoarthritis in the future?
So I think the survivorship of PAO, both from a symptomatic point of view and also from a prevention of arthritis as judged by them needing hip replacements, is extremely good. And the latest data coming out to sort of with modern techniques out to about 10 to 15 years has very high survivorship rates.
And what about if somebody is not appropriate for PIO? Would you consider hip replacement, even though they might be in the 30s and 40s with osteoarthritis?
So yeah, so if they're not a good candidate for a PAO per se, but they're having significant hip symptoms, then absolutely, I think a hip replacement is a viable option. I mean, the pain in these patients is not always coming from the sort of wear and tear that you would see in a classically arthritic hip. It's coming from a combination of instability, pain from the chondrolabral junction, and from wear and overload at the acetabular rim. All of these are going to be solved by a hip replacement if the other option, and perhaps the preferable option of a PAO, is no longer available.
Yeah, and one of the concerns of especially my patients having PIO is the long rehab and the weight-bearing status. So what would be a typical journey of a patient having PIO, and when can they expect to be back to normal levels of activity?
So yeah, it is a lengthy operation. I like it a bit though that it's an operation for the very long term. The classic situation is perhaps 3, 4, 5 days in hospital. They'll be home on crutches and not putting an awful lot of weight through it for the first 6 weeks. By the first at 6 weeks, building up to the first 3 months, they'll be getting back to a lot of more normal activity. You expect them to be doing a reasonable amount of rehab, perhaps less load bearing, more on the bike at that stage. Between 3 and 6 months, again, you're starting to ramp up that level of activity. And by 6 months, the osteotomy is starting to approach healing. I would normally plan to take the osteotomy screws out at about 9 months. At this stage, if there's any residual labral pathology, then you can perform a hip arthroscopy to deal with that. So ultimately, what I say to my patients is you should be looking at about a year post-op in terms of returning to normal and higher level activities.
And what are the common complications or things people need to be aware of after having a surgery like PIO?
Yeah, so I think there are some potentially big complications from a PIO. Thankfully, they're not terribly common. Like all operations, there are small risks of infection or developing blood clots, and so you'll be on blood thinners for a while after the operation. One of the main things that we try and avoid is any damage to the major nerves or the blood vessels during the operations. Clearly, that would impact on the outcome of the PAO. There is a risk of developing an unwanted fracture. Now, that may happen during the surgery, but it may also happen afterwards. And stress fractures around the osteotomy do occur. Thankfully, most of these do heal, although they can slightly prolong your recovery.
And finally, about the role of rehabilitation in this process, how do you think the role is? Do you think it's a crucial part of the post-surgical care?
Yeah, it's vital. I mean, as with a lot of young adult hip surgery, the performance of the operation is by no means the whole package, and it's absolutely critical that both patients engage with good rehabilitation, and you also have rehabilitation performed by people who are familiar with the procedure and the outcomes in this particular patient group.
Yeah. Finally, thanks, Mr. for sharing all your insights. So where can people find more about you? And if they want to consult you regarding getting an opinion with hip problems, where can they best find more information and possibly looking into consultation?
So on the NHS, I work at St George's Hospital in South London, and we take referrals from all over the UK. Privately, I work through the Fortius Clinic, and I practice both in central London and also in West London. You can find all the details, both my NHS and private practices, on my website, www.jonathanhutt.com.
Thank you. Thank you, Mr. Hutt, for the insight. And sometimes when rehab has failed, it's useful to know which surgical pathways and the specialists to refer to. There are a few more points which I want to raise following up from that interview with Mr. Hutt. Is looking into the subgroups which you might see in your clinic. So from my experience with the young active hip population, usually I find there are 3 subgroups who come with hip dysplasia. The first one is somebody who had his hip dysplasia when they're young and was treated, but later in life they get symptoms, usually in their 20s or 30s. The second is who had no symptoms when they're young and they're totally asymptomatic till their 20s, and they become symptomatic after some training load. So it could be, for example, a runner who's always done 5 to 10k without any pain, and they're preparing for the first marathon and they get their symptoms, or they start doing some high intensity training. So this is the most common group I see, somebody who start noticing symptoms because there has been a recent change in the training load, and usually it's related with weight bearing and impact based training like running, marathon, plyometrics or something of that sort. The third group is usually women following childbirth. So they usually get some sort of symptoms when they're pregnant, and usually after delivery it gets worse, and it might have been misdiagnosed as pelvic girdle pain, and they have ongoing hip symptoms. So when you look into all these 3 subgroups, it's nearly all of them are female, usually between the age of 20 to 35, and extremely difficult to diagnose without an X-ray. They have the classical presentation like hip impingement or lateral hip pain, and many times both in the NHS and the private sector I've seen X-ray reported as normal when there's a clear case of hip dysplasia. So it can be very challenging for clinicians, especially if they are not used to this type of patients or they have awareness of the typical presentation. So the second group is definitely the most common which I see. Now when we look into the clinical signs and symptoms, they're pretty much very similar to hip impingement. Same age group, activity related hip pain, C sign, groin pain, lateral hip pain, buttock pain, and many of them will have limping, clicking, catching, night pain. And all the tests which you do for impingement are also positive for hip dysplasia, and there's no specific test which can differentiate between these two. So we have to be aware of a limitation of a clinical examination. Although history might be useful, there's a lot of patients where there's an overlap. So if you're struggling, then imaging might be useful to help us to differentiate between hip impingement and hip dysplasia. I was fortunate to be involved in a systematic review which was published in February 2019, which was led by a hip specialist, Mike Riemann from the States, where we look into the clinical and radiological test. And the radiographic measures are complex and they might need expert clinicians. So these sort of patients are best managed with someone who has knowledge on both the diagnosis as well as imaging options. So this was a useful piece of article which I came across in Frontline. raising awareness. So the whole point of this video was to raise awareness on dysplasia. I'm really passionate about raising awareness on young adults hip pain, and one of the conditions which gets missed is hip dysplasia. Hopefully this video was useful. Find below the links of our clinic as well as links of Mr. Jonathan Hutt. I hope you found the video useful. Thank you.